Okay. We're going to start. We have a full agenda for this workshop. We're all here, the team is here. I want to welcome all of you to this presentation. This afternoon, we're going to discuss the work of wfot regarding quality in occupational therapy and the use of quality indicators. And you can see on the slide that I want to acknowledge the Quality Indicator Working Group. It's an international group, and the group led the development of the information and resources that we're going to be presenting today. We're pleased that many members of this working group are able to be here today to assist in this presentation. Just so this is what we are planning to do. We're going to provide you a brief overview of the Quality Indicator Project objectives and activities. We're going to discuss why the use of quality indicators in occupational therapy is important. We're going to describe our tool, Quest, which is the Quality Evaluation Strategy tool, as a conceptual model for defining meaningful indicators for occupational therapy. And we're going to outline how Quest has been used. It has been used to evaluate pediatric telehealth practice, to plan a new occupational therapy service, to teach students about quality and occupational therapy. So, I'm going to give you a little history. My name is Sandra Bressler, and I was in the past program coordinator of practice development. So this project was in my portfolio in 2014 when I became the program coordinator for practice development. So just this is my involvement with the project. So I have seen it developed for many years, and it's been very exciting. I'll walk through it though now. A project report was developed in 2015 that provided recommendations to wfot for further work on quality indicators. In 2015, a second phase of the quality indicator report was initiated with the objective of defining a global set of indicators that describe occupational therapy in an interdisciplinary practice environment. The first draft report was developed by the Quality Indicators Working Group for this second phase in 2018 that outlined a conceptual model, core quality indicators, and an implementation process for the indicators. Then we move on to pilot testing. Pilot testing of these elements was conducted in 2018 in sites around the world. In 2019, a report was published on the initial work of the project team, followed by a formal launch of the project that was renamed Quest, the Quality Evaluation Strategy tool. The project has now entered phase 3, which involves dissemination using a broad array of resource activities. And you can see the dissemination activities. Quest has been promoted in a number of ways since its introduction, including wfot communication channels, such as the wfot website, e-newsletter, and social media. A Quest online course is also free on the WFOT learning platform for your information, and presentations have been provided in countries around the world, including South Africa, Rwanda, Israel, United Kingdom, France, the Philippines, Australia, Argentina, and Canada. Articles have been published in publications such as the WFOT Bulletin and the AOT OT Practice magazine. So our outcomes so far. Since the introduction of Quest in June 2020, over 850 people have completed the Quest online course. We are so pleased about that. We're also pleased about all the activities, but this was very exciting. And then we reviewed the online course evaluations. And in January 2022, we found that people were highly satisfied using Quest. 94% of participants found the tool helpful for their practice, and 94% of the participants plan to use Quest in their work. So needless to say, we were very pleased. Okay, next, I am going to introduce to you Claudia von Zweck.
Thanks. So during my section, I'm just going to give you a brief introduction to Quest. As Sandra just mentioned, we do have an online course, plus we do have a number of resources up on the website to help you become familiar with Quest. So this is just a brief run through, but hopefully at the end of today's session, we'll get you to try some of it, and we have worksheets for you that will guide you through the process. But I'll just introduce some of the concepts today. So quality indicators are tools, screens, and flags that are really used to document, monitor, evaluate, and improve occupational therapy. And occupational therapists use indicators for a number of different reasons. First, of course, to improve health outcomes, to enhance satisfaction with the services we provide, and to optimize the efficient use of services. So Quest is a tool that we developed that has 7 core quality indicators, and they're meant to be generic. When we say core, that they're generic for all settings, regardless of the location and the population that you're working with. The information that you can generate using the 7 indicators is of interest to a number of different people, including individual therapists to improve your practice, managers who may want to look at comparing practice over a number of different parameters, clients who want to make sure that services are provided to them in the right way, researchers who may want to use it to generate evidence for practice, regulators who want to ensure accountability to the profession, accountability to the public for the services provided by the public, by the profession, and funders to ensure that they get value for the funding that they put into occupational therapy. So quality is a really broad concept, and so there's a number of ways that you can go about measuring quality. And so what we've done with Quest is that we've developed a quality indicator framework that we used in order to define the core indicators. So the framework on one dimension looks at the various dimensions of quality that need to be measured. So it looks at what needs to be measured. And on the other, on the horizontal plane of this matrix, we identify quality perspectives. And that's really looking at how quality is measured, and it's looking at quality measurement from different perspectives. So I'll explain that a little bit more as we go along. So first I'll talk about the dimensions of quality that we look at for using Quest. Appropriateness, which is really looking at if the right services are provided in the right place by the right person to the right person. Sustainability, whether or not resources are available in the long term without threatening future supply of those resources. Accessibility, looking at the availability of services in terms of cost and time and other types of resources. Efficiency, and whether or not we're using services optimally. Effectiveness, whether or not evidence-informed practices being used to attain the goals that are expected from occupational therapy. Person-centeredness, so whether or not people are satisfied with the services that are provided. And lastly, safety, as to whether or not we can provide services in a way that reduces harm and avoids incidents. So, as I mentioned before, Quest also looks at measuring quality from 3 different perspectives, because we realize that a number of different factors can influence the delivery of occupational therapy. So we look at quality from the perspective of structure, process, and outcome. Structure being environmental factors and resources. Process, looking at more from the perspective of how service is delivered, and then also measuring outcomes or the changes that result as a result of the service. So this slide illustrates the 7 core quality indicators. The availability of competent occupational therapists, long-term supply of resources, ability to access services, optimal use of resources, success in attaining occupational therapy goals, satisfaction throughout service delivery, and incidents resulting in harm. So by using this 7 core indicators, we get a really holistic measurement of the occupational therapy service. So from the structure perspective, we're looking at whether or not the availability of competent occupational therapists and sustainable resources. From the process perspective, we're looking at whether or not people can access the services of evidence-informed services that optimally use resources. And lastly, whether or not we attain goals while also maintaining user satisfaction and ensuring safety. So the indicators that I've just described are core indicators, and they're meant to be used in all different occupational therapy settings. But then in order for you to be able to utilize them within your own practice, they need to be defined using SMART criteria. And when we say SMART, we mean that they should be specific, measurable, agreed upon, relevant, and timely. And so we've we've developed a 2-stage process for developing SMART indicators. One, where we first look at what the quality expectations are around the service, and then to delineate what the core indicator, to really define the SMART indicator from the core indicator. And that means looking at how you're going to calculate that outcome, how you're going to define any of the terms that you use within that indicator, and looking at where you're going to get the data that you need in order to be able to measure that indicator. And it's important to define the indicator in a smart way in order that it becomes more reliable, so that it would be the same measurement regardless of the setting or the person who would be using the indicator. So that's a really brief overview of what Quest is, and we thought what we'd like to do now would be to just illustrate how other people on the project team have used Quest in their own practice.
So, my name's Camilla Cox. I'm the OT and therapy lead within Haringey, within Barnet, Enfield and Haringey Mental Health Trust in North London. It's a very large borough. We've got over 260,000 residents, and it's recognised to have one of the most prosperous areas in the UK and also one of the 10% of the most deprived. And I work within Haringey. Just to set a bit of context, this is within the NHS. We've got a long-term plan, which is written by the government, and it sets out the government objectives over the next 10 years to improve healthcare, both physical and mental health, and a detailed implementation plan. Within mental health, and particularly within the community, we're calling this a community transformation. We want more place-based care. We want more access to mental health within primary care, integrated services between NHS, local authority and voluntary care sector. We want annual health checks for persons living with severe mental illness and increased support for people to access paid employment. We needed an increase of diversity within our services within the community. And through this, we got funding to develop an occupational therapy service. I was very fortunate to step into this role at this time when money was coming in, which is more unusual. And so have the pleasure of creating this service with a senior team lead, Band 7, a senior occupational therapist, a Band 6, and a new graduate, although a year into practice now, a Band 5. We developed the service from last summer, and so we've just had our first anniversary. And we decided to start by having a time-limited intervention, which was 12 sessions over 6 months, up to. And we accepted referrals from across adult and older adult services. So we've got acute care, we've got community locality teams, as we call them, and we've got early intervention service, a psychosis service, and various psychological services. So we accept referrals from across all of those areas. So, having been part of this program of developing the Quest, we used the Quest to design this service. Invited all the staff to do the online course. We use QSA, which is a quality improvement program within the NHS, and so everybody's been also invited to do this training, and we have to use it in conjunction with the Quest. And we have monthly sessions to evaluate our services and to build up the service design and write an operational policy for the service. So I'm just going to pick out a couple of the strengths. Because we had lots, and this is just some of the ones that we did. So there was a value for occupational therapy. We'd seen that OT services within the community had been a bit diminished over the years. People had moved into generic roles. And so the protected time for occupational therapy had been a bit eroded away. So we needed occupational therapy services to come back into our communities. It was a new service, so we had the opportunity to a bit of autonomy to develop it how we saw best. Some of the weaknesses: it was a new service, so lots of unknowns. Some of the OTs coming in had been in generic roles, had been in urgent care, or were new graduates, so needing to build up their skills and knowledge to do assessments and intervention for time-limited services. And we needed to work within this time limit. Opportunities: Haringey is a thriving community with lots of partnership organisations that we can, and voluntary sector organisations. There is so much going on. We could be part of the many services that are involved in trying to reduce inpatient admissions, and that felt like a really good opportunity for us, and to develop a group programme, and often doing this in partnership with some of the community organisations as well. Some of the threats: time travel, which I'll travel across the borough, which I'll come more onto, lone working and associated risks, continued uncertainty around COVID-19 and other climate crisis-related situations. And some of those others, but I won't go into all of them. Okay, so I'm just going to do 3 of the measures, just for the interest of time. So appropriateness: we needed the team to have 3 appropriately trained occupational therapists to deliver time-limited interventions, so that we would have the number of agreed, that had done the agreed training over the number of occupational therapists. Of course, we are a new service, so we are still developing what the training should be, but we've done things like trusted assessor training to be able to prescribe equipment. We've got MoHost training in-house. All the occupational therapists have now done the creative model of occupation. And so then we're also looking at things like whether we need somebody in the service who's done sensory integration training. Sorry, the model of creative ability. And then we would look at our data sources, so training available, funding available to do the training, and what approaches have then been adopted, and looking at our mandatory training as well. And we can use our HR records to check on those things. So for sustainability, as I mentioned, it's quite a large borough, it's very busy, there's lots of traffic. So looking at ways that occupational therapies can deliver their services across the community using low admission travel options to reduce the need for travel and to be able to deliver their interventions within the time limits. So the calculation would be the low admission travel choices adopted or alternative delivery ways of delivering the session over the numbers of travels completed. So looking at whether people are going on the bus, and quite recently somebody got a parking ticket, and they had to pay out of their money, so they're like, right, well, I'm not using the car anymore, so I'm going to go by bus. And so actually, but when you reframe that into a sustainable model, the other day we were talking about this and we've got a it's kind of uplifting that you're part of that. They have also just really reduced the traffic that can come in and out of the hospital by putting big planters in the middle of the road and one-way systems. So there's a lot of concern about that, but actually it pushes us to then look at using scooters or electric bikes or going by bus, and if the roads are quieter, then it increases the accessibility of the community by alternative means. Obviously, the COVID pandemic moved us very quickly into telehealth, video conferencing, telephone calls as well as a means of delivery of our service. So accessibility, we need 80% of our referrals to be appropriate. So the number of appropriate referrals over the number of referrals received. As I mentioned, we're taking referrals from a lot of different services. So a lot of it is about communication to our various teams as to why you might refer, when you would refer. So is somebody at the right point in their recovery? Quite often people are in a crisis and they're not able to, because it's time limited, we haven't got that time to build up those relationships if somebody's really in crisis and then begin the work. And that might change along the way if the resource increases or the demand increases. So we would need to define what is appropriate. We need to see about ADLs or interventions. Quite often we're known as the ADL service. So we're trying to reframe the narrative about referring for occupational therapy, and then the occupational therapists having more autonomy in making that decision. Quite often when they're referred for an ADL, they then have intervention and it reduces actually the need for that. So it's all about these communications with our teams, but there is many of those teams. And of course, if we increase the number of appropriate referrals, then we increase the accessibility. So we've been using Quest. The team have said how useful it is to have a framework to design when there's so much uncertainty in designing new services. And we've continued to do the monthly sessions as we develop more of the measures and evaluate the service as we go forward. Thank you.
The case study I'm going to share with you is really about how I incorporated this quality indicators work into my teaching with our undergraduate students at the University of Cape Town. So our program at UCT is a 4-year BSc program, and this introduction happened during the COVID-19 pandemic in 2020. And it was introduced as part of our 4th-year practice management module. So the teaching approach that we took was in 2020, because we suddenly had all of this time, because our students couldn't go out into practice placements, they actually did the wfot online course, which was fantastic. So they ended up with a certificate as well. And I think that was a really great learning opportunity, but it obviously does take a bit more time than what was in the curriculum. So last year I gave them just a preparatory reading, and then we had an online lecture where we, which I'll explain a little bit more how I did that. And then this year, it's actually quite weird, but now it's going to be face-to-face. Now I'm actually quite nervous about doing face-to-face teaching again. Isn't it funny how it goes? So these are just the student learning outcomes here, which I put together. I'm not going to read through them. I'm happy to share them with you. But obviously, because I was introducing it, it's a pretty basic level for a bachelor's degree. But I thought it was really important that students had some kind of concept about quality and how it could be measured. So just to share the teaching plan. So I gave them a bit of a background about quality indicators and the Quest tool. And then we developed, in collaboration with one of our clinical educators, she developed a case study of a work assessment unit setting where the students actually go. Not all of them go there, but some of them go. So it's something that's familiar to them because they also do visits there. And so we used that as an example for them to actually develop the quality indicators. And then they worked in small groups in breakout rooms on Zoom. And the small groups were given a task. So they worked through the whole Quest framework. And then they came back into the big setting and they shared their findings. And I got them to document it all on a Google Doc. So it was great to download it and put it on their learning management system afterwards. And then I just got feedback from them and summarized the session. So in terms of the work practice example that we gave them, I worked with the clinical educator and she did the SWOT analysis because it would be really hard for the students to do it if they weren't actually in the setting, and some of them wouldn't have been that familiar with it. So we identified, we gave them that SWOT analysis, and then the first small group task was that they had to determine the quality expectations. Then they came and gave feedback, and then they went back into their breakout rooms to then define the SMART indicators for step 2. So the outcomes were, and I didn't measure this formally, but the students were really positive about the session when I asked them for feedback afterwards. They found it really helpful. And one of the big bonuses was that the case study is now available on the WFOT website. And then what that led to is Lucilla saying, "Oh, fabulous, she'll translate it into Spanish." So now it's available in Spanish as well. So that's the real joy of participating in these kind of programs. Yeah, and that's it from me.